Thank you for coming, everyone, again. So we have delighted to host Dr. Catherine Broome from the MedStar Georgetown University, professor of medicine. And I had the privilege to meet with her a year ago in one of the mutual meeting, and I really impressed from her knowledge and her wisdom. So we will be discussing about the PNH and treatment options with her. And we have we have a one case only today, and this is a 45-year-old female patient with a 3 years of classical PNH disease with granulocyte clone 95 and red blood cell clone size of 40%, presented for second opinion. She's been on weight-based ravulizumab every 8 weeks for last 3 years with ongoing monthly red cell transfusion dependency for the last 1 year. She had a bone marrow biopsy which showed erythroid hyperplasia with no MDS changes. So the first question is gonna be to answer what should be the next step to understand the etiology of transfusion dependency among the PNH patients who is on C5 inhibitor.
So I think that looking at this schema that was published a year or so ago really helps us to try to understand. So for me, first thing to think about is reticulocyte count. This patient had a bone marrow biopsy, which shows that they should have an adequate capacity to respond with an adequate reticulocyte count. Young woman, so we want to make sure that she's not iron deficient, of course. And then we have to think about extravascular hemolysis. And we can talk a little bit more in the future slides about how being on C5 inhibition lends itself to the appearance of extravascular hemolysis in patients that have PNH, but it is probably one of, next to bone marrow failure syndromes, the problem that causes ongoing transfusion requirements.
Okay.
With weight-based ravulizumab, less likely that this patient is having a pharmacokinetic or a pharmacodynamic breakthrough. With intravascular hemolysis, that happens a lot more when patients are on eculizumab. So with ravulizumab, I don't worry as much about the pharmacokinetic, pharmacodynamic breakthrough.
Okay, great. So I think what we're gonna give a little bit more detail about this patient. Hemoglobin happened to be 6 to 8, LDH was 540, with no changes before next due date of the ravulizumab. Reticon was 6%, indirect was 4, and then there was undetectable haptoglobin, and DAT was passed for complement. So how often do we see extravascular hemolysis in the setting of C5 inhibitor? And if you can a little bit talk about the clinical significant EVH, that would be nice too.
So the pathophysiology, or why this develops, of course, is that as you block complement activation in the terminal portion of complement cascade, you're gonna, by definition, have buildup of things above that terminal blockade. And so in patients that are on C5 inhibitors, you continue to have generation of C3, you continue to have generation of C3 byproducts with regards to C3 convertase. And one of those is C3b, which gets deposited on the surface of red blood cells. And C3b is a very powerful opsonin that results in extravascular hemolysis. And that extravascular hemolysis is taking place both in the liver and in the spleen. I would say that in any patient that has PNH that's on a C5 inhibitor, there is 100% going to be some extravascular hemolysis. There's going to be some deposition of C3b on the surface of those erythrocytes. How clinically significant it is, I think, is still a question that we're trying to answer, but most people are estimating that clinically significant causing patient symptoms, requiring transfusions, maybe is on the average of 20 to 30% of patients that are on a C5 inhibitor.
Okay, got it. And you also mentioned on your slide that the Austin and the University of Leeds group mentioned that there is no increased risk of thrombosis among the EVH patients. That's also interesting, right?
Yeah, I think that that's really important to think about when you're thinking about what are the aspects of PNH that are going to be most associated with morbidity and mortality. Of course, thrombosis is at the top of that list, and we know that that was the leading cause of mortality in PNH prior to the advent of C5 inhibition. So, if a patient is having a small amount of extravascular hemolysis, they're not symptomatic from the standpoint of shortness of breath or other symptoms, they're not transfusion dependent, then that extravascular hemolysis may not be causing them any clinically significant problems.
Okay, got it. Thank you. So, when we should be concerned for EVH, I think you touched on this. Anything to you want to add?
No, I think that, EVH and clinically significant EVH can appear sort of at any time in a patient's course. And so, this patient had had a few years of adequate control of her disease and then sort of developed in the last 1 year more clinically significant problems that appear to be related to EVH. Sometimes this can be sort of seen at the very beginning of treatment with C5 inhibition, and that can be sort of an inadequate initial response. Or some people talk about it as sort of a loss of response later on in the therapeutic intervention. I think each time you think about EVH, you need to go back to that schema that we put up at the very beginning and be sure that you're reevaluating the patients for other potential causes of anemia as well.
Okay, great. I think it's very important. So, I want to also ask this question. How often do we see a DAT negative extravascular hemolysis? Is that something that you have been encountering?
So I have had that occur in patients, and I think that if you have all of the markers of hemolysis, you have an elevated LDH, you have an undetectable haptoglobin, you have a pretty significant reticulocytosis. Even if the DAT is negative, I would encourage you to consider doing sort of a more sensitive assay that you can work with your blood bank to get, because sometimes the erythrocytes that are being opsonized related to C3b are being opsonized so quickly that you can't pick it up on the DAT. And so I think you have to still respect what else is going on, even if the DAT is negative. In my clinical experience, that's usually a less than 10% kind of a phenomenon, but we do have a few patients that we have and are managing who we were able to send out higher sensitivity assays to find the complement C3 component on the surface of those red cells.
Okay, got it. Thank you for that explanation too. So, and I think this is also interesting question to answer. How often do we see the breakthrough intravascular hemolysis with C5 inhibitor? And I'm happy if you could do a eculizumab versus ravulizumab, and that way, just to clarify BTH with each agent.
Yeah, so I put in the data on ravulizumab. I think many patients have switched over from every 2-week eculizumab to every 8-week ravulizumab. The benefit of ravulizumab, in addition to the every 8-week administration, is that it is a weight-based dosing. We don't have that data for eculizumab, unfortunately, and so I think that the rate of actual pharmacologically related breakthrough with ECU is a little bit higher. But these data are for a 4-year long-term follow-up with ravulizumab. And you can see, sort of the data here. Published estimates vary in how they're reported in clinical trials. But if you look at sort of combined estimates, it's somewhere around 19 to 21 events per 100 patient years for patients treated with eculizumab, and about 6.8 events per 100 patient years for patients treated with ravulizumab. And most of these are, in fact, related to infection and an elevation of, complement activity in patients that are on the C5 inhibition.
Okay. Yeah, interesting. Okay, I think we can move. And how often do we see the iron overload with C5 inhibitors?
Yeah, so in patients that are on C5 inhibitors, there are a few mechanisms that may be responsible for iron overload, including a reduction in renal iron loss, and then suppression of hepcidin levels, which all sort of conspire to create a positive net iron balance, which then leads to iron deposition in the reticuloendothelial system. There's not a lot of great data on the overall incidence, but I think everyone is now agreeing, as we have been following these patients on C5 inhibitors for a number of years now, that patients should be monitored for the presence or for the progression of iron deposition and treated accordingly.
Okay, but there is no estimated
I could
incidences.
not find anything in the literature about an overall incidence. That may be something that, we start to hear about in the next few years. I think you also want to be careful about interpreting your ferritin results, because these patients could have also sort of underlying ongoing inflammation. So we just want to look very closely at these patients and monitor them carefully.
Yeah, perhaps with their MRI and MRC.
Correct. Correct.
Okay, great. So what will be the next step for this particular patient? So apparently she has EVH, and that is very transfusion dependent, and she really hassling with this transfusion necessity. So what would you be recommending at this point?
Yeah, so I think at this point we have a couple of options. We would like to probably consider a proximal complement inhibitor. And you could do that in two ways. You can do it in a therapeutic switch to some of the proximal complement inhibitors that have been approved and demonstrated efficacy as standalone therapy, or there is the availability of an add-on therapy to her current C5 inhibition that will inhibit proximal complement activity and decrease the extravascular hemolysis.
Okay, that's awesome. So I think we'll go individual ones. And let's say the patient, because of this EVH, switched to proximal inhibitor. I on purpose made this vague because it will give us some opportunity to talk about each agent. So can you go over the proximal complement inhibitors?
Yeah, so the ones that are currently approved, at least in the United States, include pegcetacoplan. And pegcetacoplan is a C3 inhibitor. And so what you are doing is you're moving up your inhibition from C5 to C3, which will not allow the activation and the generation of C3b or C3a. And so without C3b being generated, you're not going to have any deposition of C3b on the surface of those red blood cells, which then decreases extravascular hemolysis. You also cannot generate C5b without the activation of C3. So by inhibiting in the proximal area of the complement cascade, you're stopping both intravascular and extravascular hemolysis. And I think in the next slide, we have the data from the pegcetacoplan trials. So there have been several different trials looking at pegcetacoplan in PNH. And you can see one of these is depicted here, where patients who were having an inadequate response to C5 therapy, which was eculizumab, were randomized to either stay on eculizumab or switch to pegcetacoplan. And the blue line is the pegcetacoplan. You can see that the mean hemoglobin improvement was fairly significant, whereas if you stayed just on the C5 inhibitor alone, you continued to experience the extravascular hemolysis. Safety data are good with regards to pegcetacoplan. The one thing that is a little bit concerning about this particular agent is that there were in the clinical trials a fairly high number of patients that did experience breakthrough intravascular hemolysis, and how to deal with that, I think, still remains a big question for many people. Some treaters chose to give an extra dose of pegcetacoplan. Some treaters chose to give an extra or a rescue dose of C5 inhibition when patients did experience this breakthrough hemolysis. But that is something to be aware of if you are treating a patient with pegcetacoplan alone. And these are the three trials that they did, Paddock and Palomino, and you can see the breakthrough hemolysis in Paddock was about 9.1%. Hemoglobin does definitely increase. Facet fatigue score does definitely increase. There was no increase in infections, but remember that all of these patients are in fact vaccinated against pneumococcus, haemophilus, and meningococcus. And that's important when you're thinking about a more proximal complement inhibitor with the C5 inhibitors. C5 is really only vital for meningococcus, but these more proximal inhibitors, you do need to be completely vaccinated.
For all the encapsulated bacteria. Okay, and yeah, how about the factor B?
So complement factor B, I thought we'd just talk a little bit about it. It circulates as an inactive proenzyme. It only becomes activated after it's cleaved by factor D. Factor D can only cleave factor B when it's bound to active forms of C3, which is C3 plus a little bit of water, or C3b. It is a very quickly escalated chain of events. So there's a lot of capability to generate a huge number of active factor B molecules in a very short period of time. So let's go to the next slide. So iptacopan is an oral factor B inhibitor. And these were adult patients who had evidence of active hemolysis and no complement inhibitor therapy in the prior 3 months. So they were randomized to monotherapy with iptacopan. And you can see that LDH levels did decline. Hemoglobin levels did in fact increase, and the mean number of transfusions was significantly decreased as well. And on the next slide, if you look at all of these results, 2/3 of the patients in this phase 3 trial got iptacopan. 1/3 continued their standard of care therapy. Almost 2/3 of the patients in the iptacopan arm got a hemoglobin level above 12. Need for blood transfusions was down. Most common adverse events were headache and diarrhea. And then COVID-19 infections were seen. This trial was done during COVID times. So if we go back to the iptacopan, I think, there's a couple of things to think about as a clinician if you're managing a patient on this drug alone. One is that it has to be taken multiple times a day. It has a very short half-life. So if patients miss doses, they are then susceptible to having the ability to activate the complement cascade. The second is that during times of increased complement activity, there may be an opportunity for very quick amplification of factor B activity above and beyond which the drug can actually control. And so there have been incidences of breakthrough intravascular hemolysis, some of which have been severe in patients that are on iptacopan.
Okay, yeah, very interesting. And these events are not something that is predictable ahead of the time. Like EVHs, yeah, they may have some low-hanging complement activation and lead to EVH, some hemoglobin being low. But these breakthroughs can be anytime in any condition that is related to complement activating condition. Is that right?
Absolutely. And that can actually vary even, from patient to patient. So it's really difficult to predict, right, how much factor B somebody's going to generate in response to a simple viral URI versus COVID versus a gastroenteritis. So it is very unpredictable, even from patient to patient.
And so the patient has to be very vigilant if they happen to have any intravascular signs, just to report to the
Absolutely, and
provider.
report them back to their clinician, immediately, so that appropriate action can be taken, whether that's additional dosing of iptacopan, so additional dosing of the factor B inhibitor, or whether that's some kind of rescue with a C5 inhibitor.
Gotcha.
And I think what we all worry about the most about these breakthrough intravascular hemolysis events is, as we have discussed, sort of that low-grade extravascular hemolysis is not associated with a risk of thrombosis, but an acute event of intravascular hemolysis breakthrough could put your patient at risk for a thrombotic event.
Okay, I think it's important to make that.
And then we have factor D. We talked about how factor D is very important in activation of factor B and in complex with C3. It's a key rate limiting component in the alternative pathway, participates in that amplification loop. And so what we have available with regards to factor D inhibitors, so if we look at how do we define intravascular breakthrough hemolysis? There's a lot of different answers to this, and I think it depends on which expert you ask. It is definitely the subject of a lot of debate, but using markers of intravascular hemolysis is certainly one way. And so looking at a rapid decline in hemoglobin and hematocrit, a marked increase in LDH greater than 2 to 3 times the upper limit of normal, hemoglobinuria, which should not be present in extravascular hemolysis, patient having symptoms And then, some people define it as having to have the presence of a complement amplifying condition. Other people don't necessarily add in the complement amplifying condition as a prerequisite for the definition of intravascular breakthrough hemolysis. So I think we missed talking a little bit about danicopan, which had a phase 3 trial. And so danicopan is a factor D inhibitor. It was studied as an add-on therapy to either ravulizumab or eculizumab. So you keep your C5 inhibition constant as a protection against intravascular hemolysis, and then you add on a proximal inhibitor to address the extravascular hemolysis. And it showed a favorable benefit risk profile, no meningococcal infections, no discontinuations due to hemolysis. And you can see the increases in hemoglobin that occurred when you do get control of the extravascular hemolysis. So definition, we talked about this a moment ago, and there was a meeting, and there was a large group that got together to try to come to some kind of a consensus with regards to the definitions of breakthrough hemolysis. And so the consensus committee said an acute drop of hemoglobin greater than 1.5 grams compared to the patient's baseline, presence of a newly elevated LDH greater than 1.5 times the upper limit of normal. And then this group also said caused by a known complement activating condition, which was a recent event or a condition that may have increased complement activity. So you can see they tried to define the symptoms, including shortness of breath, chest pain, abdominal pain, dysphagia, erectile dysfunction, etc. So how often do we see this breakthrough hemolysis with proximal inhibitors? If we look at the data that has been published related to pegcetacoplan, which you'll remember is the C3 inhibitor, 3 patients had to discontinue due to breakthrough hemolysis with LDHs greater than 3 times the upper limit of normal in the first part of the 16-week study. And then during the 48-week study, 24% of patients experienced physician-reported hemolysis, and 6 patients discontinued the drug due to hemolytic events. The explanation is that, of course, there is an increased number of cells of the PNH clone that are surviving. And so consequently, if you are able to overcome the C3 inhibition with a complement amplifying condition, then you have more cells that are exposed to the potential for lysis. If we look at iptacopan, the pre-specified criteria that they used for breakthrough hemolysis were an LDH of greater than 1.5 times the upper limit of normal, and increased over the last 2 assessments, plus a greater than 2 gram hemoglobin decrease or significant signs or symptoms. And when they looked at that, they had 9 clinical breakthrough hemolysis events in the clinical trial. So it is something that is seen in patients on proximal inhibition when used alone. It is something to be aware of. I think it's something to discuss with a patient, because a lot of these are shared decisions that we make with our patients, and how risk averse or willing to take this potential risk are patients, how compliant are patients with regards to taking their iptacopan pills, etc. So I just think it's something definitely to be aware of. And, Dr. Bat and I both sort of mentioned that while extravascular hemolysis is certainly something to think about. It's certainly something that can cause patients symptoms, quality of life symptoms, etc. The intravascular hemolysis in PNH is really what is associated with the most devastating mortality-inducing conditions, which certainly are the thrombosis. So how does this happen? It can happen either with pharmacokinetics, so either low or inadequate drug levels, and that leads to a suboptimal inhibition of complement. It can be pharmacodynamic, where infection or other inflammatory states elicit a really high level of complement activation, generally transient, but it overcomes drug-induced C5 blockade. BTH, while taking either C3, factor D, or factor B inhibitors, has honestly not yet been fully characterized. There are some theories about pegcetacoplan, which is the proximal inhibitor that has been approved for the longest period of time. So the theories are that the half-life of pegcetacoplan is relatively short, and that plasma levels may decrease below the threshold of efficacy because of a missed dose, or remember, this is an injection that patients are doing themselves with an injection device, and so there could be issues related to that. And then a recent study did show that exposure to higher and more sustained doses of pegcetacoplan could minimize this risk. And then incomplete inhibition is going to result in a pretty high hemolytic potential. With C5 inhibition, the thing to think about is that if inhibition is incomplete, only one membrane attack complex can be formed for each molecule of C5 that escapes inhibition. But with incomplete pathway inhibition at the proximal level, such as with pegcetacoplan, each molecule of C5 convertase can actually catalyze the cleavage of several molecules of C5, leading to the assembly of multiple membrane attack complexes, potentially resulting for more significant breakthrough hemolysis. So that's the issue with that proximal inhibition versus terminal inhibition, is the level of generation of that membrane attack complex is really different depending on how and where you're breaking through the complement inhibition. So how do you risk stratify? I think that's important to think about. And then how do you treat or salvage breakthrough hemolysis events? And these are intravascular events that we're talking about. So again, that same consensus group came up with classification system ranging from mild, moderate to severe. And then, what are you doing? So you're monitoring patients very carefully, right? Daily, every couple of days. You can absolutely transfuse patients. I'm personally not a big fan of corticosteroids, but that's available to us. Prophylactic anticoagulation, I think, is really important to think about, especially if the patient's not currently on anticoagulation, and continuing that until you feel very confident that that breakthrough event is under good control. You can continue the current complement inhibitor schedule and give nothing else and just wait for it to resolve. You can shorten the dosing interval, or you can treat with a complement inhibitor with a different mechanism of action. So you can add a proximal inhibitor if on a terminal inhibitor. You can add a terminal inhibitor if on a proximal inhibitor. I think this is an area where there's not a ton of consensus. And I think, a lot of people who manage PNH patients approach this problem in a variety of different ways. There's been no clinical trial that really gives us data-driven guidance on how to manage breakthrough hemolysis on any one or all of our currently available complement inhibitor therapies. So I think the next question that Dr. Bat proposed was, when do I think we should use proximal with terminal pathway inhibitors? And I said that I would consider it in patients who maybe had a significant thrombotic event in the past, and I was very nervous about there being the possibility of breakthrough intravascular hemolysis in patients who had experienced breakthrough hemolysis on a proximal inhibitor alone. So if I had made a switch, or patients had primarily been placed on a proximal inhibitor and they had had one or more events of intravascular breakthrough hemolysis on that proximal inhibition, I would consider a very detailed conversation with the patient about the potential benefits of being on both. And then I think anybody who has had an end organ damage that intravascular breakthrough hemolysis may exacerbate, I might want them to be sort of on both proximal and terminal pathway inhibitors. I think, again, this is my personal opinion. We don't have a lot of data yet to try to inform us about who are the best or most appropriate patients for both proximal and terminal inhibition utilization. And then prophylactic antibiotics, again, I think that choice is very variable from clinician to clinician. I personally practice in an urban environment where access to emergency care is readily available. All my patients have their patient card information that they are on complement inhibition. I'm pretty diligent about their vaccination schedules, so I don't place them on long-term antibiotic prophylaxis, but they do all have a dose of antibiotics that are available to them to utilize in an emergency if they can't get themselves to an emergency room or urgent care, or to take on their way to the emergency room or emergent care. But a lot of other clinicians do place their patients on antibiotic prophylaxis. I don't think there's a right or wrong answer. I just think you have to have, very frank and ongoing reminder conversations with patients. People can get a little complacent after they've been on therapy for a long time. So it's always my practice to remind people sort of every time I see them that your risk doesn't go away just because you're vaccinated, and you do have to be very vigilant about this. So what's my choice of complement inhibitor for newly diagnosed PNH, and why? So personally, I'm still placing patients on a C5 inhibitor, and I am basing that choice on a much larger data set and much longer term safety and efficacy data than we currently have with any of the proximal inhibitors. I also am concerned about breakthrough intravascular hemolysis. I like knowing that my patients have received their dose of medication. I don't love relying on patients to remember to take pills. So for me, this is still where I start. But I'm very happy that we have multiple options for patients. I do discuss all the possible options for patients, and I would not allow a patient to start on a proximal inhibitor if that was truly what they felt was the best for them, their lifestyle, their situation. But if patients ask me, what do I recommend? Right now, I'm still recommending a C5 inhibitor. So cost, I am honestly not qualified to comment on the differentials about cost. One of the things I think about and to certainly discuss with patients is that when they're receiving an infusion, whether it's in the clinic or by, home care infusions, which almost all of my patients that are on C5 inhibition get that through home infusions versus a pill that they are going to, get from a pharmacy, specialty pharmacy. It is billed to a different part of their insurance. And so patients, I think, have to be very savvy, and as clinicians, we have to use the time of our staff to really work through for patients, what is the financial implication for them for each one of these therapies. Does a patient's insurance have a pretty good coverage for something that hits the IV portion of their benefit versus prescription benefit and those kinds of things? So it is complex, and it does take some work to work through for patients, what is going to be their personal financial liability for each of these particular medications. Certainly, institutions are happy when the financial liability is on the patient and not on the institution. But I think, we're still learning and working through all of those things. When do I refer them to stem cell transplant? Well, certainly any patient who has evidence of an underlying bone marrow failure disorder that's associated with PNH really should be referred for evaluation to, treat sort of this overlap that we have in PNH and bone marrow failure. And, just a reminder that just because you didn't see evidence of bone marrow failure at the time of diagnosis of PNH does not mean that that cannot evolve over the course of the patient's disease. So again, I think, thinking about cytopenias and evaluating them thoroughly, each and every time that they appear in our patients, reevaluating them if the therapy that you chose to institute doesn't fully address them is really important so that we don't miss the evolution of an underlying bone marrow failure disorder in our patients with PNH. So what other complement inhibitors or regulators are promising? So I listed here, those that are sort of currently being evaluated. There's Coversin, which is a recombinant protein that's actually derived from a protein in the saliva of ticks that blocks complement-mediated hemolysis at the C5 level. There's BCX10013, which is an inhibitor of factor D. There's BCX9930, which is also a factor D inhibitor. There is OMS906, which is a humanized monoclonal antibody that binds to MASP3. And MASP3 is a serine protease that activates profactor D, which activates the alternative pathway upstream from factor D. This is in the lectin-associated area, which is that middle mannose binding lectin pathway of complement. There's cemdisiran, which is a small interfering RNA that suppresses the liver production of complement component C5, and it's used in concert with pozelimab, which is a monoclonal inhibitor of C5. There's HRS 5965, which is a factor B modulator, and there's MY008211A, which is another oral factor B modulator. I think, what comes of all these trials and what we may have available is going to be interesting as we move forward over the next 3 to 5 years. Are there modulators of factor B that can overcome the amplification issues that we seem to be seeing with iptacopan? Will this MASP-3 inhibitor answer all those questions that we have about, overcoming complement activation and breakthrough intravascular hemolysis with proximal inhibitors? Remains to be seen, I think, for all of these, but it's an exciting time for PNH. I think it's an exciting time for learning more and more about the complement factors, about our ability to inhibit them and what that actually does with regards to this disease, both short-term and long-term management.
Thank you, Catherine and Dr. Broome. I'm back. Sorry, my my computer crashed. I don't know what's going on. So, I mean, I think you touched on a very important aspects of complement cascades and each pathway being involved, especially the alternative pathway and other modulators through the lectin pathway. There's also, I think, KP103, something like that, that combines the proximal with the terminal pathway that was presented at ASH. But really, it's very important. I mean, I do see in the audience Dr. Lusotto here. So I would love to hear his voice and his insight in addition to your presentation. Dr. Lusotto?
Thank you. I wish to thank very much Dr. Catherine Broome. I think you've done a wonderful overview. And since Dr. Bat is asking me, I do have a couple of comments. One is you pointed out the fact that breakthrough events may be more severe with proximal inhibitors. And you also explained the molecular reason. I would like to emphasize that the crucial point is what you also mentioned, namely the very high absolute and relative numbers of PNH erythrocytes. As from your case history, this patient had almost complete 90% PNH granulocytes, but I think, if I remember, only about 30 or 40% PNH red cells. That is rather typical. But a patient on pegcetacoplan will have, instead of having a hemoglobin of 7 or 8 or 9, will have a hemoglobin of 14 and will have 90 or 95% PNH red cells. Therefore, the so-called breakthrough hemolysis might mean hemolyzing 2/3 or more of his total red cells. That is a real crash, a potentially catastrophic crash. Now, given my age, I've managed many patients with PNH in what I call the pre-eculizumab era. And therefore, to be a bit crude, I would say I was used to breakthrough hemolysis. That's the precise clinical manifestation of untreated PNH. And I'm not so scared. I've never, in the pre-eculizumab era, I've never lost a patient from hemolysis. If need, you give him a blood transfusion. But I never had a patient with 15 grams of PNH red cells. It didn't exist before. So I think we must be very aware of this being a iatrogenic situation that, as you quite rightly pointed out, requires a great attention. And to put it very bluntly, I would say that to have a vial of eculizumab in the fridge might be a very apt precaution. I know that from the regulatory point of view, this may not be very easy, but I'm talking from the clinical point of view, I think that would be ideal. The other comment I have is that you quite appropriately mentioned about the question of anticoagulants. You mentioned that perhaps in a different context, but I take the opportunity to mention a fact that we don't like very much. There is no doubt that with C5 inhibitors, the rate of thrombosis has decreased dramatically, not dramatically, let's say substantially. But unfortunately, it still happens. And I'm afraid that has made people a little bit complacent. And I had it to my fellows and students that you must do a thrombophilia screen to all PNH patients. And frankly, I think that should still be done. Because if there is a thrombophilic factor added on to PNH, there is a risk even with complement inhibition. And the third point is purely, if you forgive me, perhaps a little bit of nomenclature. So people like to say that a breakthrough hemolysis on C5 complement inhibitors is what is it? An adverse event, a side effect, or something like that. Quite frankly, you said quite rightly that it causes clinical problems only in a proportion of patients, primarily those who remain transfusion dependent. Or who have a minimal increase in hemoglobin, so they still have significant anemia. But in pathophysiological terms, it is not. It is found in all patients. I have never seen a patient on C5 inhibitors who does not have C3-coated red cells. They all do. Of course, the Coombs test, as you said, may or may not be positive. That's a question of sensitivity. But if you do the flow cytometry, you always find those cells. So I'm afraid I call it a regular iatrogenic phenomenon, which may or may not have clinical relevance, but we must be aware that it is there. And therefore, I concur fully with what you said, that, ideally, the combined inhibitors of proximal and terminal pathway, well, I think on the long run, that might be actually ideal. It does come against, you have very elegantly skated on the issue of prices or costs. And well, I worked for many years in Africa, and I feel humbled by the fact that these drugs are simply not accessible. In so many countries, I reckon in about 2/3 of the world. So 2/3 of the world is still in the pre-eculizumab era. And I think we should all join forces to correct that problem. Thank you.
Dr. Broome, do you want to comment?
I agree and concur with everything that Dr. Luzzatto said, and thank him for such wonderful comments. I agree that it is very sad that there are many patients in the world suffering from PNH who don't have access to anti-complement therapy because of the cost. Hopefully, as more and more of these drugs are available, cost will start to come down, but that hasn't happened just yet.
I also concur what you said, Catherine, Dr. Broome, and I mean, I cannot express myself to Dr. Lusato's being so pioneering the field and really mentoring so many people, including from a lot of PNH gurus now. Thank you, Dr. Lusato, for being pioneering for this field, and we learned a lot from you, and we continue to learn from you. Thank you for being part of this advocate. Thank you, Dr. Broome, again. I think that was a fantastic session. I'm sorry for my computer being crashed, but we'll make this widely available recording for anyone in the around the globe, and hopefully more biosimilars will come in the near future, and we will see more widely distributed complement inhibitors for the underserved countries. Again, have a good weekend, and thank you for being part of this initiative.
Thank you.